It's on. Hi everybody, my name is Ashley Brady and I am a child life specialist down at Children's Health in Dallas, or Children's Medical Center Dallas, and I live in the suburbs of Dallas. Keep saying Dallas, but and I have been a child life specialist for close to 15 years. I don't really remember. A really long time. I went to Texas Tech University. I know you guys are at Louisiana Tech University, so I feel a little kindred spirit there. And I have only ever worked at Children's, and I have actually worked with your professor, and I have to say, she's pretty amazing. Keep listening to what she's teaching you. You have a lot to learn from her, and I have all the confidence in the world that she will prepare you for practicums, internships, and then your first dream job as a child life specialist. Like I said, I've only ever worked at Children's. I did my internship in Memorial Hermann, Houston. Loved it. It was a great experience. And I did my practicum at a hospital in Lubbock, where I went to college. And I have a little bit more about me. I have worked on a nephrology floor, hemodialysis, chronic kidney disease transplant. I have worked in radiology, surgery. I've done neurology, which I'm going to talk specifically about today. And then currently I'm working PRN, which means work as needed. So I work on the weekends, about 3 shifts a month, covering pages and consults from the ER all the way up to the ICU, and anything in between: oncology, diabetes, asthma, GI, board, everything. We cover everything. I have 3 kids, and so they keep me busy and kind of really have helped me hone some of my child life skills, and kind of, I think you'll see that reflected in some of my interventions. I really focus a lot now on normalization. Just having kids at home, I see the importance of creating normative activities. So you might hear a lot of that sprinkled in throughout my case studies that I'm going to share about. So with that, we're going to go ahead and get started. I have wrote down, if you see me looking down, it's because I've written down some different case studies I want to talk about. So one of the first patients I want to talk about is an infant. He was, when I first met this patient, he was 3 weeks old, and he came in with seizures, and they ended up diagnosing him with vanishing white matter disease, which, if you've never heard of it, it's not a big deal. I've never heard of it either. So my first thing I did was Google, and then took what I found on Google and went and spoke with the nurse practitioner and the charge nurse, just to make sure I had a really good understanding of what the diagnosis was prior to ever meeting with the patient and the mother. The mother also didn't speak English. She was from an Arabic country, and it was really hard to find a translator with her specific dialect. And Dad spoke English and would translate for her, but he was also an Uber driver. Interestingly enough, he would do Uber drives from the hospital, take them where they needed to go, and then bring people back. So he would be in and out kind of all day long. One of the things I learned about vanishing white matter disease was it's just like it sounds. The white matter in the brain, which we know the brain has white matter and gray matter, and the white matter is slowly disintegrating or vanishing, which means that the baby would eventually die. They don't know if the baby would die 3 months, 6 months, a year, 2 years. He's still alive today, 3 years later, so he's alive. He's not doing too much because his brain is just vanishing, but he was very uncomfortable when I first met him. He would do this thing, we call it neurostorming, which you'll hear in the ICU a lot. You'll hear, oh, they're just storming today, or not a good time, they're neurostorming, which basically means all the input and neurons and everything is just making the patient really uncomfortable, and you see them kind of spastic with their movements. They might be crying out, yelling out, whining, just kind of groaning. You can just tell that the patient is very uncomfortable. This particular patient was neurostorming a lot, and one of the things we found that really soothed him was vibrations, and he eventually got too big for the bouncy seat that we use at a lot of hospitals, so we actually worked with OT and got a vibrator type thing that went underneath the mattress and would vibrate the whole mattress for him, and that seemed to soothe him. One of the things I wanted to do with the mom, and so you heard me talk about normalization earlier, knowing this baby was going to eventually die and knowing that the mom and I had a language barrier, I really thought, well, play we can communicate with any child, right? With playing and mothers, I think I could go in with this iPad with Pinterest of baby footprint, handprint ideas. So making the patient's feet little mistletoes or a love bug for Valentine's Day. So I would, every time the patient was admitted, I would go in with acrylic paint and canvas and my iPad with Pinterest pulled up. And Mom and I would pick all kinds of handprint and footprints to do for the patient. So they were really happy, seasonally ones that she could pull out at Christmas times or Valentine's or 4th of July, whatever whatever you were decorating for seasonally, there would be a part of the patient always with her. That was really important for me to create lasting memories and a fun thing for the mom to do in the hospital. Gave her some kind of control. Also, we had Kendra Scott used to come up to the hospital a lot, and they would bring their color bar. So I would take mom, and I really encouraged her. At the color bar, we did the patient's birthstone, and we made jewelry. We made a necklace, bracelets, earrings with his birthstone. So I just wanted to give mom things that would be lasting for the patient. Because a lot of times when we do bereavement things, the footprints, I always feel like are a little bit sad. They're black or they're red or they're blue, just kind of colorful, but just kind of, it's like, oh, this is the last thing I did with my child. So I wanted happy, normative things. And that the mom really appreciated. And I feel like as a child life specialist, that was the only thing I could really do for this patient due to all the things that were going on medically. And like, sometimes just if I brought in a mobile or a aquarium, it would overstimulate him. So kind of trying to figure out ways to help him and be supportive of him without adding to the neurostorm or to all that was going on in his body. So that's that patient. And I wanted to talk too about how I explain the brain to kids, because a lot of times when I worked on the neurology floor, I would work in the epilepsy monitoring unit, which is our seizure unit. And so a lot of the kids would come in having seizures. And how do you explain seizures to kids? So how I would do it is I would talk about how the brain is the boss of our body, because most kids understand being the boss, that they know the boss tells you what to do. So the brain tells our body what to do. The brain tells us to breathe. The brain tells us what we smell, taste, feel, when to eat, when we're hungry. All of that, the brain communicates to us. So I would tell kids, when you have a seizure, the boss of the body, the brain, has lost its Wi-Fi connection. So it's just like Netflix. When you lose it, and you just have to keep resetting, and then eventually it comes back. And so in a seizure, our brain loses its Wi-Fi. And so it's trying to figure out a way to get back, which is why the body sometimes falls on the ground and shakes, or sometimes anything the body can do, not in a seizure, can do during a seizure. So some kids would cuss, some kids, their arm would go up and down like this, or they smack their lips, or whatever their seizure was. We would talk about how it was the brain trying to figure out and kind of reset itself, and that it wasn't contagious. So all the things you would normally do for doing new diagnosis education, it's not your fault, you didn't cause it, it's not contagious. And offering a school visit, we had a great book called Taking Epilepsy to School, and a lot of the school nurses do really great epilepsy education. So I didn't really have the opportunity to do too many school visits, but I think that's a great way to get into the community with child life and to support our patients that are at the hospital with chronic illnesses to get into the schools. That was just a sidebar. So I want to talk to you guys about another patient I worked with. She was 4, and on my neurology floor, we had all kinds of things. We had seizures. We had this one I'm going to talk about, optic neuropathy, which is it's kind of like muscular sclerosis, so MS, with the neurons and the how the neurons in the myelin sheath communicate to the brain. And in this particular patient, because we know it's optic, I knew when I saw it on the census, optic is eye. So it is basically her body not being able to communicate to the brain, and she would go blind. It's an autoimmune disease. And so she would be in the hospital for a treatment called Plex. And Plex, which I think is really important to remember for my presentation, but Plex is also known as plasmapheresis, and it would be a 2-week treatment. And when they came in, they would get treatment every other day. So they would, the first day they get a vascular catheter or hemodialysis catheter, but it would be up here in the neck. So just imagine a catheter with 2 lumens coming out and kind of with some tape, and it just kind of hung out right there. So they would get the catheter put in for Plex, and then every other day they would have treatment. On their non-treatment days, that's when we would make plans for playroom, things like that. And Plex could take up to 2 to 3 weeks. So if it's every other day for a 2-week or 3-week cycle, they were in the hospital for quite a long time. This particular patient, when she would come in blind with her body's response to what was going on with her body, she didn't start getting her vision back till about Plex treatment 4. So if that's every other day and 4 treatments, it would be about a week. And she would get very frustrated. I would try to take her to the playroom, and one time she fell playing kitchen and like moving over to something, she couldn't see it. So she ended up becoming very frustrated in playroom when she couldn't see. So we made plans to, I would do bedside play, get the assistant in the room doing bedside play, but bring everything to the room that she liked. And then when her vision increased and got better, we would go back to the playroom. But it was almost like it was more traumatizing to her and kind of reinforcing what was wrong with her body. Also, for just a life hack, if you ever have a kid with a catheter right here, one of the things we did was a headband. So it's just like a cotton headband, and it could go around and it would keep it propped up instead of hanging over. The hospitals don't really have a cute or soft way to do that. They would kind of just use the string. So finding headbands that would get donated, or even from the oncology unit, they would give us some like hair bows and things, really helped just to kind of normalize it, make it more comfortable for the patient. They also complained a lot about the tape sound, keeping them up at night. So that was just something I always, when talking to kids about getting that catheter, talked a lot about. That tape is going to kind of keep you awake at night. And so talking about sound machines or different things we can do to maybe get more comfortable with that tape. Also, how I explain, I'm going to talk about, so I talked about optic neuropathy, and then there's this other diagnosis called Guillain-Barré, or there was another one called CIDP. I'm not really sure what it stands for. It's something really big. Nobody at the hospital used the real word, so I never learned it, but it's CIDP if you wanted to Google it. And what I would do is, always in my bag of tricks is a pipe cleaner. You can do a lot with a pipe cleaner. So I would talk a lot about, this is our nerves, and then talk about what the job of the nerves is. The job of the nerves is to communicate to the brain. Depending on their age, you can go into more detail. If they're school age, a lot of times they're starting to learn about their body, learning that we all have cells, that there is a nervous system, that it's connected to the brain. Once they're in high school, they know neurons, myelin sheath, all of that. So I would kind of tailor this. I use this for all the kids who had this particular illness, or any illness where the neurons were affected. But so this is the nerve or the neuron, and then I would say this straw is the myelin sheath. So this is what kind of protects and covers the nerve. And then when I talked about CIDP or optic neuropathy or any of those types of things where the myelin sheath is affected, so the myelin sheath is damaged, and that's what causes the body to go blind, or if you have CIDP, you don't walk, things like that. So, and then we just take the scissors and we cut holes all throughout. And I'm not gonna, for time's sake, I'm not gonna do the whole thing for you guys. But I would just cut little bits and pieces off and show if it's not protected, if the myelin sheath isn't able to do its job, it's not able to communicate to the brain. Remember, the brain's the boss of our body. If the brain's not getting all of the information, our body doesn't know what to do. So this I used for, I think, most of the diagnosis for MS, CIDP, all of the ones I've talked about. Another patient I want to talk to you about, this one's one of my most interesting and probably one of my more emotional cases I worked with. He was a 7-year-old, and he was in our epilepsy monitoring unit. And just a little bit about the EMU is when they come into the hospital for seizures, and if they're admitted to the EMU, it's to watch for seizure activity for 24 to 72 hours. They get 26 electrodes stuck to their head. So it's, you know, I'm not a scientist or anything, but it's something about the way where they would put the electrodes would communicate seizure activity. So it's very traumatizing for kids with sensory issues because it's cleaning 26 different spots with like a scratchy Q-tip and pink soap. They mark on them, they're measuring with tape measure, and then putting the lead on, and then they go on and they put this tape and then glue that smells horrible. Put the glue on, and then they use a little air gun connected to the oxygen in the room, and they dry the glue on the child's head, wrap them up like a mummy, and they are connected to that the whole time they are in the hospital. And that, the electrodes are attached to a thing that communicates to the doctors in a computer and a video. It video records seizure activity. It's videoed in the room. There's video cameras in the room with sound. And families know this, they're aware, there's no trickery or anything like that. But it was a great way. And then parents hit a button connected to the electrodes. If they saw their child having seizure activity, they hit the button. Then the doctors can see if when the parent thinks it's a seizure, if it's actually a seizure. Or maybe the kid's having seizure activity, but nobody's catching it. We do this a lot for any head injury, so it could be up in the ICU, trauma, child abuse cases, all of that, just to see the extent of the brain damage. So remember I said it was monitored with video, and these kids could go to the playroom 3 times a day. There was cameras in the epilepsy monitoring unit playroom so that kids could play in the playroom and we could see what was going on. So this particular patient had been in the hospital like 2 weeks, and the mom kept saying he was having seizures. No one had really seen the seizure activity. They went ahead and admitted him to the EMU. And on camera, you hear mom say, "You better have a seizure right now or you're not going to playroom." Sure enough, the kid starts kind of flailing and having a seizure. Obviously, it's not seizure activity. It really started making the doctors aware of maybe some other things that the mom had said was wrong with the patient wasn't. So he had a G-tube, all kinds of other medical things that they determined were not medically necessary, and actually removed the patient from mom's care and diagnosed the mom with Munchausen's by proxy, which also, if you have time to Google that one. It's basically where the caregiver makes the child sick for attention. That's like a very condensed thing. So my role in that case, besides doing medical play and talking about the actual procedure of putting the leads on, was I helped to tell him that he was being placed in foster care, and worked with our social worker. And one of the things I did for him is when mom and dad left, he was all alone, and then we moved him rooms so that the family wouldn't know where he was if they tried to come back to the hospital. And I just got him new bedding, and I just thought, okay, what's normal for this patient? He doesn't know his mom has a mental disorder, and all he knows is his family. And so what can we do to emulate that tonight so it's not so traumatizing? So I helped give him a bath, brush his teeth, do all of those activities of daily living, read him a nighttime story, get him tucked in, into bed, all of that stuff, just to get him. I didn't feel right about telling him, you can't go live with your mom and dad, they don't keep you safe, to see ya, my shift is over. So that's one of the times I stayed late, and I had it cleared with my supervisor and all of that. But I just think sometimes the best thing we can do as child life specialists is to provide normative opportunities, because nobody else is thinking what normally would be going on, what normally would this patient be doing. So that was something that was different for me, instead of just talking to the kids about the leads and the glue and the air and what can we do to help the air. One of the things that sorry, I'm kind of jumping all over. I'm trying to get everything concise and condensed, so I'm not on your video for a long time. One of the things I did in the EMU a lot was, so the kids would be laying down while the technician was putting the leads on. And one of the things the child life specialist before me did, and I just thought this was a fantastic idea, was give the kids a handheld mirror so they could hold the mirror and see what was going on behind them. So they could see, because they could feel everything, but they couldn't see what was going on and see that it wasn't needles, that it wasn't, that it was just stickers essentially that are being glued to your head. Not that, I'm not sure if that's any better than needles, but I think it kind of helped. So I think that was always really great, just always trying to think of ways. We know when kids are getting procedures, we need to explain the 5 senses. And so if they can't see what's going on, sometimes that's pretty scary. It's the same as if a kid's getting an IV and we block them with an iPad, is that going to add to their anxiety, or is it going to help their anxiety? If a kid needs to see to help soothe their anxiety, we need to find a way to make that happen. The last case I'm going to talk about is one of the kids I got to be really close with. She's 18, not a kid. But this particular patient, teenagers are my favorite population to work with. I could hang out with teenagers all day. I just think they're grumpy little people, and I love getting the breakthrough. I love hanging out with them. I love being sarcastic with them. This particular patient had that disorder called CIDP that I talked about earlier. And what happened to her is she was a typically healthy kid, actually had a full ride soccer scholarship for college, was going places, was super active. All of a sudden, this autoimmune disorder attacked the brain, and she was paralyzed. She couldn't move her legs. And the cause of it was the CIDP. So she came in, we did an LP, MRI, CT, so I talked to her about all of that. And what I do to explain an LP is I use a slinky. Always my bag of tricks. You can use it for anything, distraction, sensory, or explaining an LP. So even though she was 18, she was 16, 17 at the time, but it talked about how this is our spine, and then when you raise it, you can kind of see the cartilage that's in between the spine. And when we get an LP, they have to take fluid from here. And so sometimes we need to lay in a certain way that makes our back. If we're right here, it's not so, there's not a lot of room for the doctor to get what they need, the fluid out. But if we go like this, we can take the fluid out a little easier. And so she was awake and alert for the LP, so doing just the basic support, hers was listening to music and talking and telling jokes. So I just read a joke book actually the whole time. Try not to make her laugh, because if they move, that's kind of bad. But side note. So, and then I worked with her a lot because after all of these tests, she then went to surgery, never had surgery before, to get that vascular catheter. So we talked about that. What's it going to look like? What it's going to feel like? You're going to be in the hospital for about a month. And she's lost everything. She's lost her soccer scholarship. She missed prom. But your professor actually planned a really awesome hospital prom she was able to go to. But all of this stuff just happened to her in the way she carried it was very stoic. I'm going to get through this, and not really breaking down, not really, just kind of flat. And so we talked a lot. I talked a lot with her mom about letting her grieve her loss of movement, letting her grieve her loss of going to college, because the doctors now said she needs to stay very close to home, maybe a community college, because stress also brings on the CIDP. So she did the Plex treatment for a month, was able to go home, was fine, and then has continuously come back every few months for the treatment, and has a big social history. One of the things I worked really hard with her was setting goals for the future. Like, okay, we know we can't be a soccer star. Maybe we can be a soccer coach. What is that? What do we need to do to be a soccer coach? Maybe we can volunteer at the YMCA with kids. Maybe we can go start taking basics at community college. And then she ended up deciding she wanted to be a massage therapist because she really liked those treatments in the hospital. So then working with her on researching, where does one go to massage therapy? I called the massage therapist and said, hey, next time you're there, would you mind in the room giving her a massage? Would you just maybe talk to her a little bit about what is it like to be a massage therapist and things like that. But so kind of back to my normative development and like, what can we do to help normalize the environment? One, we can validate that this is a huge life change. Nothing I'm going to say is going to make it better. Nothing the doctors are going to say are going to make it better. So we don't need to just keep being positive all the time, but we can listen and we can validate and we can kind of try to come up with a new plan. And then for this disease, she has to do physical therapy. And something that was really cool was one of my old Child Life coworkers is now a physical therapist over at the place she was getting outpatient therapy. So we were able to kind of talk, and my friend could use her Child Life skills within her PT skills. And then she would tell me kind of what exercises she was supposed to be working on. So then I could check in with her inpatient, like, have you been doing your homework? Have you been doing your exercises? She is able to regain function. She can walk, but just when her disease flares up, she can't walk anymore. So kind of working with PT to get kind of co-treating, figuring out what we can do to help promote her following along with her treatment plan for that. And then the last diagnosis I'm going to talk about, I'm not going to do one case study because I had a lot of these kids, and it's just so complex, and I could talk about it for hours. But one of the things that would come to the neurology floor a lot was a thing called functional movement disorder or conversion disorder. Basically, the kid or the teenager would be so stressed out from something, a lot of anxiety, school. One girl had been at a summer camp and came home. But anyways, the body responds to stress by losing function in something. So walking, talking, moving their arms. So it's not a fake diagnosis. It's not the kid is faking it, but the whole cause of it is psychological. There's no medical reason for the patient to not be walking or to not be talking or to not be using their arms or whatever way their conversion disorder was working. And the treatment for that is physical therapy, occupational therapy, and psychological support. There was only 2 clinics in Texas, one in Fort Worth and one in Lubbock. So they would be on my unit for about a month or 2 and then go to the clinic once it was finally diagnosed. all of these kids would be, they would get the doctors would start ruling out in the ER. Like, that's very scary. You're walking one day, the next day you're not. You're talking one day, tomorrow you're not. So they would come in, so we would do an MRI, LP, lab draws, all of that. So previously healthy kid, all of a sudden having all these different procedures. So we know in the child life world that that's pretty traumatizing. So if you're already here because you're having stress and that's what's causing your body and your brain to not really communicate, imagine then adding a new hospitalization on that with all kinds of things. And then you add on top of that parent stress, because the parents, it's a really hard diagnosis to get that your child isn't really sick, but they are sick, but there's no medical cause. It's the brain responding to stress. And so the way we do that is a lot of therapy, PT, OT, and psychological counseling. And so one of the things that was my role within, I worked a lot with PT and OT and psych, but was to kind of model to parents that you don't want to go in and say, how's your foot today? Are we able to walk today? Any better, any worse? But just kind of not allow the patient to perseverate on what was going on with their body, but to really say, hey, playroom's open. PT says you're good to walk. Let's get up and walk. We can shuffle, but we don't need to take a wheelchair. We can get a walker, but not a wheelchair. But a lot of times the parents would want them in a wheelchair, and then the parents are perseverating on what's going on with the child. And so then it's just like this endless cycle of nobody's getting better. The patient's getting worse, because then it's adding more anxiety to them. Like, oh my goodness, why can't I walk? Why can't I move my arms? Why can't I feed myself? So then that adds to the conversion disorder. So I think in those cases, I learned a lot of just reaching out to my coworkers and reaching out to the PT and OT and kind of co-treating and following their lead and knowing my role and knowing what I could do, but also knowing they know more about this. And so what can we do to work together and kind of make up a plan? And so I did a lot of education too with these patients. And I would always say back to, the brain is the boss of our body, and stress affects our brain. And when we are stressed from school, there's so much on kids and teenagers, sports, school, we need to be perfectionists at everything. We've got to get the highest GPA. We've got to be the best at everything. Or maybe it's an abuse situation. You went to summer camp, something happened, and now you can't walk. So something happened in your body that caused stress, and the way your body reacted was your brain not communicating to your legs or not communicating to your hand to move. But you are not crazy. You did nothing wrong, but we do need to figure out how to fix it. And how we fix it is by PT, OT, doing what they say, following the recommendations, and going to counseling and being vulnerable and listening to the recommendations of them. And kind of modeling that for parents as well. And just to encourage the parents to trust the medical team. Nobody thinks their child's crazy. And that also, we had a lot of kids with chronic headaches, and so sometimes that was stress induced, not necessarily a medical reason. There's no brain tumor, it's just your child's really stressed out. So what can we do for headaches? And so we actually, one of my other coworkers made a functional pain scale, which was from 1 to 10, because these kids would say, I'm a 5 on our FACES scale. I'm a 5, but they're up painting. So we have to believe that you're a 5, but your action's not showing us you're a 5. So on the functional pain scale, it would be 1 through 10, and 1 is I can do all my normal activities, and maybe 6 is I'm uncomfortable, but I can do a puzzle, and a 9 is I can hardly get out of bed, and a 10 is I have to lay in bed, I can't move. But maybe a 5 is I have some pain, but I can get up and walk to the playroom. And so that kind of helped to help the patients define their pain, help the nurses kind of understand the patient's pain. And then anytime you create something that you're going to use to help assess a child, but it's not validated, it's not reliable, it's not been studied, it's not been in a cohort, all of that stuff, you can't really, nobody can use that as a diagnosis. Like, the nurse can't say the patient was an 8 on the pain scale, because that's not true, but the nurse can say through Child Life's functional pain scale, patient said they were an 8, meaning they can't get out of bed. And so I would always introduce it to parents like that. Like, this is just something we made to help communicate with the nurses and the doctors your child's pain, but it's not, like, the FACES scale is reliable and valid, this is just something we made up that seems to work pretty good. And maybe one day we'll get there where it's researched and in journals and people are using it. The doctors really loved using it. The psych team really liked using it. So it was something that the whole unit used and kind of had a really good understanding of that. And then I would always put it in the chart so that when you would read my note, like provided the pain scale, they would know what I was talking about. I always wanted people to be on the same page and on the and kind of follow along with what I was talking about. So that's all I can think about on some of my more interesting, not boring, neurology case studies. But basically, it's just kind of using your assessment skills, talking to staff to figure out if you have the correct understanding, because neurology is huge, and but kind of finding, like, getting in the swing of things, of knowing, like, most kids on this unit are going to get an LP, they're going to get an MRI, they're going to get a CT scan, they're going to get an EEG for the seizures. So getting a good understanding of that and just remembering to prep kids using 5 senses and moving on that way, and talking with coworkers if it was something kind of out of my wheelhouse. Thank you guys for spending some time with me this evening, and I hope you have a great day.